right, so it's my pleasure to introduce our next speaker, Dr. Praveen Mummaneni, who is my partner and also the Joanne O'Reilly Endowed Chair Professor at UCSF. He's also the surgical lead for our perioperative services. So, Nima here, if any issues with your OR, you gotta call Praveen.
So I will promptly not fix them. I'm just curious of this audience who's here today, how many of you are surgeons? Okay, how many of you are nurses? Okay, and how many of you are physicians who are not surgeons? Okay, so we got a mix of surgeons and nurses. One person, I think, was not a physician, but a physician, but not a surgeon. Okay, I just want to know who my audience is so that I can tailor what I'm going to talk about. I want to thank my research coordinators, Alicia and Vivian, who are both here, who helped me put this talk together. And let's see. Okay, I have disclosures which are here. I'm not going to spend too much time on anatomy. It's probably not what you guys are all looking for. But I do want to point out a couple things here. What I want to point out is where the vertebral artery goes when we're doing these C1-2 cases. And we really got to focus on that it comes out of this hole, the transverse process. It sits on the sulcus arteriosus on the top of C1. That's really the things to focus on. And there's issues where people have abnormal vertebral artery anatomy here. And what can happen is sometimes you can have a piece of bone that sits over the top here. Sometimes this bone underneath here can be very thin so that, when you're working up underneath here, there's almost no bone here and the vertebral artery is sitting right on top of you. Those are the two most frequent things that I see, which are a little bit altered in people's anatomy. When I do C1-2 fixation, I routinely get a CT scan. I don't get a CT angio because of the dye load, but routinely I get a CT scan so that I can figure out what's going on with the vertebral artery. When I was training, this was the main construct we did. We used to do transarticular screws, but the problem was every so often you'd hit the vertebral artery, and so people got away from these things because typically it's supposed to look like this, where you can run a screw right through the joint and up into C1. But sometimes you have the foramen transversarum riding high here, and the vertebral artery is right in your way. And recognizing that on the pre-op CT is key so you can stay out of trouble. Intraoperatively, you also have to figure out, are you going to see it? Where is it going to be? It's going to be way out here, and it's going to be deep. So what happens is there's a big venous plexus here, and people bipolar this thing. I don't recommend using a bovie anywhere near here, but if you bipolar this thing, you keep following that venous plexus out laterally, you will ultimately end up near the vertebral artery. So it's just, you got to be careful when you get out there. So these C1-2 screws really got to watch for the aberrant vertebral artery, and you have to watch for other issues like cervicothoracic kyphosis and irreducibility of a C1-2 sublux where you might get into trouble. And so, if you see a CT like this, I would not be real eager to do a pedicle screw in this because technically this little piece of bone is the pedicle here. So that's when you might want to do a pars screw. If you really have vertebral arteries that look like this, sometimes you get like a little dinky 10 millimeter pars screw here, and you might want to go down to C3. So those are all things that I plan out ahead of time using navigation and CT to basically figure out where I can put the screws. So here's a non-reducible C1-2 sublux. You're not going to be able to get a transarticular in there. And if you have pathology involving the pars and pedicle, that's another issue that you don't want to do these transarticulars. So people started doing these C1 lateral mass screws, of course, and Goal initially published it. Harms popularized it with polyaxial screws. But let's take a look at this kind of surgery and where people can get into trouble. I'm going to focus this on how you stay out of trouble with these kinds of cases. The vertebral artery complications are rare, but when they happen, they're pretty devastating and can be fatal. So we got to just be real careful. So this is a typical trajectory of the C1 lateral mass screw. It is angled just slightly medial. You can put it straight. The important thing to remember is the carotid artery is sitting right here. So if you really go deep with it, you can strike the carotid. And that's not something that I think people really think about. They're so focused on the vertebral artery, they forgot that the carotid is sitting up here. So these screws, when you look at it on the lateral fluoro, you want to be, sort of here at the back of the C1 arch on the lateral fluoro. If you're up near the front of the C1 arch or beyond the front of the C1 arch, now you're getting close to the carotid. So those are just landmarks if you're using fluoro and not nav, but I usually do tend to navigate these. Now, the other thing which can happen is you navigate these, and if the C2 dens is broken, you can have a lot of mobility there. So then your navigation may be off. So you have to really think about, how much force am I putting down here? It's not like a lumbar spine. You can use your navigated drill guide and put lots of force. If you put a lot of force, you may displace things. And if you displace things a few millimeters, that's all you need to get into trouble here. So you have to figure out how to get these things done, what you're going to do with the C2 nerve root, which goes right in the way of where you want to put that C1 screw, and what to do with the nerve root. I used to routinely push the nerve root down and spare it, and then put my C1 screw in. The problem with doing that is then you don't have great access to the C1-2 joint, which you can decorticate and pack bone into. So probably the first 10 years of my practice, I was pushing the root down and putting the screw in. More recently, in the last 10 years of my practice, I've been now basically sacrificing the root, which I cut before the ganglion. You want to cut it before the ganglion because what happens is the afferent nerve root fibers are in that ganglion. And if you cut the root after the ganglion, you're going to transmit those pain signals right back up into the cord. If you cut it preganglionic, you don't transmit those pain signals back up into the cord. So preganglionic is where you want to cut your nerve root. So these are the potential errors to go too far forward. Where the blue arrow is, hit the carotid. Obviously, if you go lateral, you're going to hit the vert. If you go too medial, you will get in the canal. And I have seen one of our residents try to put one too medial into the canal. It just feels like a void there. And you're lucky if you don't get a CSF leak if you do that kind of maneuver. So you just got to be careful. And then you want to know, are you going to put in a C2 par screw or a C2 pedicle screw? Those are not the same. Anatomically, they are different. The par screw connects the superior and inferior articulating process and is that black line that's vertical up and down. The pedicle connects the vertebral body to the superior articulating process. So that's this more angled line here. So those two screws are not the same. This is from one of the textbooks, basically defining where the pedicle is in red and the pars is in blue. And so the par screw will go in that green-blue area. So the pedicle screw will go much more medially. And the entry points, I always ask the fellows, what are the entry points for these screws? I guess I put it up here, but just to reemphasize that, where's Sam? Sam, what's the entry point for a C2 par screw? Yeah, that's right. And Tim, what's the pedicle screw entry point? So what I say is usually you find the C2-3 medial aspect of the facet, you go 3 up and 3 lateral, that's the pars entry point. From that same C2-3 medial aspect of the facet, if you go 5 up and 5 lateral, that's the pars entry point. And for those of you who are going to take your boards, I can guarantee you that question's coming. This is the pedicle screw entry point and trajectory here. And this is the pedicle screw entry point and trajectory is very similar to the transarticular screw. It's the same entry point, just the pedicle screw doesn't keep going. It's short, usually like 20 millimeters. If you keep going lengthwise to 40 millimeters, you'll end up with the transarticular. So if you can't do a transarticular screw, do the vertebral artery anatomy, you also cannot do a pedicle screw, do the vertebral artery anatomy. So it's important things to just remember and recall. So here are the two entry points and the trajectories in red and in blue. And then the C1 trajectory and entry point right underneath the arch of C1. And again, there's the pedicle, there's the pars. So we talked about all this stuff already. Let's talk about the vertebral artery. This is a bit of an older table, but talks about people reporting these vertebral artery injuries, and I think they happen more frequently than people report. And you can even have vertebral artery injury at the C1 lateral mass screw. Because that arch of C1 can be abnormal and dysmorphic and kind of break off when you're trying to put the screw in, and then you get the injury. If you look at classic vertebral artery anatomy, it's divided up from V1 to V4, V4 being the intradural part in the brain, V1 being the origin near the C6 transverse foramen where the vertebral artery enters the foramen transversarium, and V3 is the area where people get into trouble when they start doing the C1-2 screws. So important to remember what happens with the vertebral artery. It comes up through the foramen, it sits on top of the sulcus arteriosus of C1, then penetrates the dura and goes into the brain. So on average, the vertebral arteries are 14 millimeters across at the level of C1 and 22 millimeters across at the level of C2. So they come out laterally, typically in a normal person at C2, and that's why you can do all these screws at C2. So this is the vertebral artery anatomy. This is where you're going to be putting your screws. That's the pars screw. Well, you're going to say, well, that pars screw is sitting right next to where the vertebral takes a turn before it goes into the foramen transversarium. And that is true. And the reason that the par screw doesn't get you into trouble because the trajectory is like 30 to 40 degrees superior. If you take a par screw entry point and you go straight in, you will hit the vert. This is the pedicle screw entry point, and this is fine as long as your vertebral artery is not deviated medially, and that's the nerve root, and that's a C1 entry point. And that's the transspinous process screw entry point. So let's see if this video is going to play. I think you had to click it for me last time. Yeah, it'll come along. Okay, so this is a intraoperative video of a case that we did some years back now. Probably Annabelle, you were here when we did this case. She's one of our nurses who's in the OR with me all the time. But this is a 50-year-old who had a C2 mass, and we wanted to fixate C1-2 and take this thing out. So here what we're seeing is that the nerve root is being retracted inferiorly by a Penfield, and that gives you the entry point to make a pilot hole for the C1 screw. So then the pilot hole is drilled. I usually use NAV for this nowadays, but we drill that pilot hole and we tap it, and you can see the nerve root's being pushed down here. I did not sacrifice the nerve root because this is a bit of an older case. And but nowadays I'll just cut that nerve root medially before the ganglion, and then I'll see the entire joint, and then I can drill that joint out and pack bone into it. And so tapping, and you can see again, there's some slop to this. So your navigation can be off, and it's important to understand that if you really push down hard towards the floor, your nav can be off. And what I'm doing here is I'm measuring, did I get bicortical out the front of the C1 lateral mass? And so I put the screw just barely bicortical so I can catch the back cortex, catch the front cortex, and that's a much stronger screw if I do that. And then this is the opposite side here. So if you're going to do this, let's see, is Arthi here? I don't know if she's here. Oh, she left this morning. Okay, Tim, we'll ask you again because she's not here. Do you do the right side first or the left side first? And why? Yeah, that's right. So typically the vertebral artery is dominant left. So I will typically put the C1 screw on the right first, because if you have some disaster, you have not taken out the dominant vertebral artery. Or if you take out the dominant vertebral artery, your stroke chance is pretty high. You take out the non-dominant vertebral artery, you might not even have a deficit. So right is typically where I go first. This one we did a transspinous process translaminar screw. I don't like these screws actually. They tend to not give you great resistance to rotation. They're behind the instantaneous axis of rotation, and so they are not biomechanically as strong at putting a pars or a pedicle screw in. So this is like for me now a salvage technique where I tend not to put these screws in anymore unless the C2 pars is violated by the vertebral artery and I can't get a pars or a pedicle screw in due to really weird anatomy, then I might put one of these screws in. But I try to at least get one pars or pedicle screw in, if not two. And then the next question is where you can put your bone graft here, which you got to put it in the middle because you didn't take the nerve root in this case, or I didn't take it. Okay, so I'm going to talk to you about a couple of cases of people who have problems, because I can show you all the pretty cases in the world and we don't talk about problems, and we think problems don't happen, but problems happen. So this is a 73-year-old with neck pain from a car accident. The patient has AFib, so takes Coumadin. It is a smoker, 55-pack-year smoking history, neurologically normal except for the neck pain, and as you can see, he's got the dens fracture, and he's a smoker, and he's a little bit elderly, and he's not going to heal this dens fracture. That didn't heal, so he needed fixation. Here you can see the dens fracture right there, non-healed dens fracture. And so he did not have his initial surgery at UCSF. He went to a hospital near his community for a C1-2 fusion. And does this video play? Let's see if this video plays. You may have to play it for me. It's not playing. During the case, the surgeon called me and said, I had some problems here. I saw a whole bunch of red stuff. So, what do you do now is really the question. This is what the op report said: 13 units of PAC cells, 9 units of FP, a pack of platelets. It was like bleeding that was hitting the ceiling under force, he told me. And he had a vertebral artery laceration. So you can see here, the patient was then sent to me at UCSF, and there's a hematoma here from that injury, and he had packed a whole bunch of gel foam and whatnot in here. This is the dominant vessel here. This side had screws in it. This side, he left the screws out and sent the patient over. This was the posterior fossa of that patient. So this is what happens when you get a dominant vertebral artery injury. Those are all strokes. The patient is still talking, but has some gait ataxia from having cerebellar stroke and a little bit of visual field issue too. Lucky though that the patient lived and didn't have more problems. The patient had an angiogram. It showed a pseudoaneurysm on the V3 segment of the vertebral artery. That got coiled. The patient was placed on aspirin, and then he's sent for the pseudoarthrosis treatment. So then I have to reoperate. So when I reoperated, this is what I see. I see the coils coming out of the vessel hole. So that's not usually a typical picture that I see when I operate on these, and this you have to run the thing. So, here are the things that are important. I mean, this index case was not done at UCSF, but if you have, first put in the screw on the non-dominant side, but if you have vertebral artery injury, the key things to do is to initially don't put a whole bunch of surgifoam on it because it'll embolize, and I think that's what they did at that outside hospital. No flow seal, no surgifoam. What you need to do is if you can put pressure, put pressure. If you can clip it off, clip it off. If you can't clip it off, then you just got to keep packing it and then send them to angio. But you want to put gel foam in there, large pieces of gel foam, not little dinky pieces that can embolize, and you don't want to do any flowable hemostatic agents. Those are the key steps to not get all those strokes, because the bleeding may not cause a stroke. It might be the embolic material that you try to stick in there to get hemostasis. And the first thing people want to do is grab for that flow seal and stuff it in there. And that's not the right thing to do. So, I revised it. You can see his coils there. He actually did go on to heal it. I made him quit smoking, and I put a big piece of iliac crest bone graft on the back. So when you do this bone grafting, this is another thing. I think people get so intently focused on putting the screws that they don't do the grafts. And if you don't put the grafts, the screws are going to loosen. So there's several different ways of doing these grafts. And the classic ways are Brooks, Galley, and Sontag. Brooks, easy for me to remember. I'm a simpleton anyway. So Brooks is B for bilateral. There's bilateral pieces of bone graft, and you just wire C1 and C2 with those bilateral pieces of bone graft. This is assuming you don't have to do a laminectomy. The Galley, you take like an H-shaped piece of bone, you put it on the back of C1, you wrap it around C2. And then this is the Sontag, where you take a piece of bone and you stick it in between C1 and on the top surface of the C2 spinous process, and you wire it in. And these are all nice ways, and especially if you use iliac crest, these tend to heal very well. And so I'll harvest iliac crest, and the fellows are aghast because they've never seen any crest harvested, I guess, in their residencies nowadays. But get a nice big chunk of tricortical crest, and you can stick it in there, and it heals up super. You can also decorticate the 1-2 facet joints. That's if you take the nerve root. You could do it even with the nerve root there, but then it gets tricky, and you might try to wrap the drill with the nerve root. But if you decorticate in there, you can pack graft into there, and that's a nice place for graft to be, and tends to heal very nicely there too. So this is in conclusion, and I did stay on time, Lee, so you're not going to be upset with me. If you get the vertebral artery injury, apply pressure. If you can repair the vessel and put some temporary clips, great. That's quite difficult to do in most cases. We've had one case where we were able to repair the vessel on a tumor that I was taking out, and as the tumor came out, the vertebral artery started to bleed and was bleeding vociferously, and I was able to pack it. And at the time, Mac Lawton, before he went to BNI, was with us and came over and stitched it. But I think that's very difficult to do. If you hit it on the initial attempt, you go to the non-dominant side, use that side first. If you hit it, don't go to the other side, because you can survive on one vertebral artery, often without a stroke. You take out both vertebral arteries, I guarantee you a stroke and potentially death. So don't do the other side, just stop and reconsider. If you have a problem, go to angio and coil it. I've also seen cases that get sent in where people are like, it's not bleeding now, it's all good, I'm not going to worry about doing an angio. That's not correct. You should get an angio. You should look for dissection. You should look to see if there's an intimal flap. They have to consider whether they need to sacrifice the vessel or not, and if it's dominant or non-dominant, so do get that. I'll stop there and see if there's any questions. Thank you.
Thanks, Praveen, for a great overview. I'll start off with a question. So, you mentioned that, basically you can do the wiring for the graft. and then do the facet spacers. Which one do you, in practice, prefer? And do you see differences in the fusion rate, or do you do both?
I actually nowadays will do both. The only time that I don't tend to put a big chunk of iliac crest on the back is if I had to do a laminectomy of 1 or 2, in which case I can't anymore because there's nothing to pack it, and then I have to really rely on that interfacet space. But lately, since I've been taking the route, I pack bone into the joint, and then I put a big piece of tricortical crest graft on top of the joint, and Sig showed me how to take beautiful tricortical crest grafts. He gives me a nice big chunk of that, so I've learned that from him, and I stick it back there, and with some wiring, it heals super.
Yeah, and then the other question is securing the graft down on the C1 and C2 lamina. You know, I've done the sublaminar wiring before, and you know, it's a little bit hectic, and you're always worried about, you know, you can hit the dura. What I've been doing lately is just using an Atlas cable, because you know you have the rods on either side, and you can you know tighten down. That works pretty well. I don't know. So that's one thing. And the other thing is that, you know, something that Vince Trinalis at this meeting mentioned last year is that for C1-2 fusions, you know, in China, they've been doing like just instrumentation, maybe some posterior graft, and then going back once, you know, in a year or so, once the dents are healed, just take it out, and then people kind of regain their rotation. I don't know, what's your opinion, or have you tried it in practice?
I agree with you. It's uncomfortable for the first point to try to do a sublaminar pass underneath C1 with that cable. So I've been lately either putting a cross-link across the rod and putting the graft underneath, but sometimes the graft is so big it doesn't fit. But even I've been using some Surgilon and trying to just push the graft down, and I put graft also in the interfacet space. That's been working out okay. Your second question of should you go back in after a dens fracture, just put the hardware in and then take it out. I think Chris Shaffrey talks about that too, that he tries to preserve it. I mean, it is a second operation, so I think you have to talk to the patient. Do you want to come back and have another operation for me to take this out? Or do you want to just be one and done? And, you know, for most of these folks who are in their 70s, that's the commonest patients I see this for. I would just do the one and fuse them. Because a 70-year-old coming back in 6 months, you know, with all they've got AFib or whatever else they've got going on, it's just too much. I think if you're a 30-year-old with a non-healed dens fracture, then that might consider, you know, coming back and taking it out, because they have a whole lifetime of rotation, and they will tolerate the second operation without too much trouble. That's my 2 cents, but nothing's for sure.
All right. Any other questions?
Well, I'd like to thank Lionel and Lee for putting on this great symposium. It's really wonderful to see all of you here, and thank you for coming.